Thank you everyone for spending your lunch break with us today. My name is Marissa. I'm part of the Health Equity Coalition as the professional work group, and we've been hosting these webinars for a while. It's been a few months since we've had one, so we're excited to kick back off today with this great presentation. As always, we welcome ideas and recommendations from all of you. So I would be the contact person if you have an idea for a webinar you'd love to see us host, or an idea for a speaker, or you yourself would love to speak and share some of the work that you do with our community here in Colorado. So we're going to go ahead and get started by having Jason Vitello introduce Dr. Berman. One note that I'd like to make is throughout the webinar, as Dr. Berman is speaking, if you have any questions, feel free to drop them into the chat box. I'll be monitoring that if it's anything that I can answer for you about logistics. But if it's anything for the Q&A, we'll save those for the end, and then I'll read those out to Dr. Berman at the end. We'll also have a chance for you to ask questions individually through your telephone or your computer to Dr. Berman after that as well, if you'd like to do that. So without further ado, Jason.
Good afternoon, everyone. My name is Jason Vitello. I'm the Behavioral Health Coordinator for Denver Public Health and the Health Equity Officer for the Colorado Public Health Association, and I'm honored to introduce to you all Dr. Bill Berman. He's the Director of Denver Public Health, which means he's also my boss, and a Professor of Medicine with the Division of Infectious Diseases at the University of Colorado School of Medicine. His interest in alcohol and health stems from his work in the Denver Health Integrated Safety Net Care System. I know this is a topic that he has been very passionate about and has really been instrumental in raising awareness around this issue throughout Denver Metro. An overview of the webinar itself. Alcohol is familiar to all of us and consumed by many of us. However, alcohol is the third leading cause of poor health in the United States, ranking only behind tobacco and poor diet. Alcohol can cause serious health problems for the person who consumes it, but also for others in their surrounding. Dr. Berman will review data on the health impacts of alcohol and changes in patterns of alcohol consumption. Finally, he will review interventions to decrease the harmful effects of alcohol. So thank you very much to everyone for joining us, and thank you, Dr. Berman.
Thanks, Jason. I want to start by saying that I'm going to focus on Denver, in some cases Denver County, in other cases Metro Denver, because that's what I know the best, but nothing that I say is limited to Denver County. It's equally applicable across the state of Colorado. So I just want to put that out there, that I'm using the data and things that I know the best, but this applies across the state. Okay. So I want to start by acknowledging what I think is a really complicated relationship, the complicated relationship between alcohol and our society, because in many ways we incorporate alcohol into some of our most important moments. It's a wedding toast, it's an afternoon with friends, it's time at church, it's all kinds of things. And I put in the bottom left-hand corner just another thing that's gotten quite a bit of press over the last decade, and that is the possibility that alcohol may be healthy at very low amounts. And so that's the famous J-shaped curve between alcohol consumption and the risk of cardiovascular disease. And I'll say just parenthetically that there have been questions about that, but it certainly has gotten a lot of press, the suggestion that in, quote, moderate amounts, alcohol may promote health. But as we all know, it also has many adverse outcomes on health. And so I just want to acknowledge the many perspectives. One, I'm a person who enjoys beer or a glass of wine, and many of you may as well. But I'm also a family member and friend who have seen family members and friends suffer from and even die from complications of alcohol abuse. For 30 years, I've been a primary care provider for persons living with HIV. And for all of that time, I've known alcohol as one of the leading barriers to effective treatment for that disease. I'm a health department director, and one of our primary obligations is to assess health in our community and provide information on what are the opportunities to improve health in our community. And I think alcohol While we all know it, I don't think we appreciate just how much it impacts health in our communities. And then finally, as Jason mentioned, I'm also in the leadership team of this large integrated safety net healthcare system. And I've had the opportunity to observe, to go, to see almost all the parts of that system. And what I can tell you is that alcohol impacts every single part of the Denver health system in major ways. So I'm going to just show you some of that data. This is data from a study about the ambulance system for Denver, which is run by Denver Health. And in a study of almost 170,000 calls, about a third of them were directly connected to alcohol. Having been on the ambulance on a Friday night, I can tell you at that time, it's like 75% of the calls are directly due to alcohol. And they estimate, and I think it's a conservative estimate, that it was $7 million a year just in ambulance-related costs due to alcohol and lots more. The picture is actually of something called the Emergency Services Patrol, which our ambulance group also runs, and that literally picks up people who are publicly intoxicated and takes them to detox. On a Friday night, they have 2 of those circulating full-time in our city. This just shows the impact on the emergency department. So this is in 1 year, there are about 29,000 visits to the emergency department. And of those visits in which substance use disorder was the leading indication for the emergency department visits, 36% of those were related to alcohol. And opioids have appropriately got a lot of attention in the last 5 years or so, but look and see that alcohol caused almost 3 times the number of visits to the emergency department as opioids. And to summarize, that's 29 emergency department visits per day, primarily for alcohol. The same thing's true for hospital admissions. So it's about 6 admissions per day, primarily for alcohol. And it's certainly true for Denver's Detox Center, which we also run. Of the about 17,000 visits to that facility in 2018, 93% of them were directly related to alcohol. And so that's about 46 on average per day admitted to our detox system. So you can see this is just one small snapshot of the way that alcohol impacts the Denver health system. And there are many, many other ways. For example, we're a level 1 trauma center. Most of the trauma that comes to us is related to alcohol, et cetera, et cetera. One of the key concepts of alcohol is that, like tobacco, alcohol affects many parts of the body. So while some of those I think are very well recognized by the lay public and professionals, others are less well recognized. So certainly the connection to cirrhosis and liver disease with alcohol is well known, as well as with alcohol dependence and depression. But alcohol affects every part of the body. So it's a significant risk factor for heart disease, for gastrointestinal disease, for sexual dysfunction. It's a leading cause of unintended pregnancy. It weakens bone and muscle, et cetera. And it's an appreciable cause of breast cancer. It's estimated that 1 in 7 cases of breast cancer is due to alcohol ingestion. So it impacts the user in many, many ways. And I want to highlight one of those. That's the connection to suicide. So this is a simple, small study from New Mexico in which they just looked at alcohol level in people who died, in this case, of fatal car crashes. So about 45% of them had alcohol in their system, some a lot of alcohol in their system. And this is the comparison to suicide. And it's superimposable. And I think that connection is much less well recognized than the connection between alcohol and fatal car crashes, which I think almost any person on the street would recognize. And this is only one of a wide spectrum of evidence that ties alcohol to suicide. And that's particularly important for us in Colorado, as suicide is a major health problem in any community in the United States. It's particularly an important problem in Colorado and in Denver. We have some of the highest suicide rates in the country, and I think alcohol is a key part of that. And as Jason mentioned in the introduction, the other key part about alcohol is to appreciate what it causes what health problems it causes to the person who's not using. And some of those we know right away. We all make, again, that connection to car crashes, pedestrian assault, injuries. But alcohol is very closely associated with assaults, homicide, infectious diseases, all kinds of societal costs. It's one of the leading underlying factors for adverse childhood experiences like neglect and child abuse, domestic violence, divorce, all those things. And there's a fascinating study from the United Kingdom, these are the results here, that quantitated the impact of this wide variety of drugs of potential abuse. And they split it in two ways. One was the harm to the user. And by that criterion, as you look at those blue bars, alcohol wasn't the most harmful potential drug of abuse to the user. But when you added in the harm to others, it quickly went to number one. And I think this definitely applies to us here in Colorado. So this basic concept that alcohol causes a wide range of harms to the users, but importantly, an equally wide range of harms to others is a key part of thinking about the total impact of alcohol on health. And so in summary, in the United States, it's estimated that about 100,000 deaths per year are related to alcohol. By comparison, tobacco's at about 400,000 deaths per year. And it's the third or fourth leading behavioral cause of health burden. So it's a remarkable problem. I want to just sort of set a few terms when we go to talking about patterns of harmful alcohol consumption. And you may well know these. So binge drinking is defined as a pattern of drinking that would get you to the current, what's often used as the standard for inebriation, so 0.08. Blood alcohol content. And for men, that's 4 or 5 drinks. In women, it's about 4 drinks in a relatively short time period. Heavy drinking, so binge drinking is the most common kind of excessive drinking in a population. Heavy drinking, which is drinking every day, so on no specific day might that meet the binge drinking definition, but it's more than the numbers you see there, 15 drinks for men, 8 for women. And then some people have added in that drinking in people under 21 or in a person who's pregnant are also included in a definition of excessive drinking. And so the World Health Organization uses this so-called drinkers pyramid to think about the distribution of alcohol use patterns in a population. And so it starts at the bottom with something like, obviously depending on the population, something like 40% of people who don't use alcohol. A third or so who are low-risk drinkers, that is, they don't meet those criteria we just discussed. 20% who are so-called high-risk drinkers, and so those are people who do meet those definitions of binge drinking or excessive drinking. And then 5% or so who have alcohol dependence and what we would commonly call addiction. And the point of this slide is that we really should pay attention to that yellow slice of the pyramid, because while the risks to the individual are less than the risks to that smaller group at the top of the pyramid, because there's so many of them, most of the health burdens of alcohol fall in that yellow slice of the pyramid, so-called high-risk drinkers. And this is data from a recent, very large population-based survey that provides a little bit of nuance to those patterns of alcohol use. And so it shows that 28% or so are occasional light drinkers, 25% frequent drinkers. The pattern of infrequent drinking with occasional binging is uncommon. Binge drinking is quite common, 22% in this study, and then 20% what they called high intensity drinkers. So this is a little more detailed view of drinking patterns within the United States. What's happening with alcohol use? I've spent parts of the last couple of months trying to figure that out. And here's some summary statements. Everybody initially wants to say, well, it's youth, right? It's too much drinking in youth. And I think, yes, there is too much drinking in youth. But I'll show you the data. Actually, alcohol use and binge drinking specifically are steadily decreasing among young people and young adults. But the problem is with us, the adults. There have been dramatic increases in drinking, particularly among women. That's the biggest epidemiologic change over the last 30 years. And also increases in the intensity of binge drinking among adults. And then finally, among older adults, there is an increase in alcohol use and an increase in health problems related to that, particularly falls. So this is data from Colorado, from the Healthy Kids Colorado survey over the last not quite decade. And it just shows for girls on top, boys on the bottom, that there are relatively high rates of alcohol use, but there's been quite a substantial decline So that's sort of a good news, bad news thing. I think mostly good news, frankly. And it's interesting that in this population, girls drink more often than boys do. This is just data from a meta-analysis that put together data from a wide variety of epidemiologic studies to show, again, what I think is the dominant trend in changes in alcohol use in the United States. And that's the continued increase of alcohol use in women, such that in a number of populations, women drink as much as men. And that's a huge change from 30 or 40 years ago. This is a slide which suggests that there's also an increase in the intensity of binge drinking. So this has this level 1, 2, and 3. What that means is level 1 is sufficient alcohol to meet the blood alcohol concentration of 0.08. Level 2 is twice that. Level 3 is 3 times that, so 0.24. Really, for most people, quite intoxicated. And it compares that in 2 different time periods, back at the turn of the millennium and then about 10 or 12 years later. And it shows an increase in overall drinking, and particularly worrisome, an increase in both the occurrence of binge drinking and the intensity of binge drinking. So how does that relate to adverse health outcomes? Well, it actually follows very, very closely the epidemiologic trends. So there are decreasing adverse events from alcohol among youth, still too many, but they are decreasing. Increased emergency department visits among adults for both acute complications, that's like being so drunk you're acutely ill, or chronic complications like cirrhosis. Increased rates of cirrhosis and fatal liver disease. And the biggest increases have been among young adults and particularly women. So diseases that we just don't think of as being in young women, like end-stage liver disease, are happening. And then, as I mentioned, increased rates of falls and other injuries among the elderly. And I'll show you just a little bit of that data. So this is a slide using a big national data set about emergency department visits over about a decade. And it shows that, shown in the line there, that's the rate of ED visits per 100,000 population. And so a steady increase in the use of the emergency department among adults in the United States. And yet, interestingly enough, no change in the estimate of overall alcohol consumption in the population. And how could that be? Well, I think one of the ways you could explain this is a shift in alcohol use to a more vulnerable population. And I think that's women, because the same amount of alcohol causes substantially more acute intoxication and chronic health problems among women than among men. So I think that's the explanation for what may seem like a bit of a paradox. So let's look at local data. This is binge drinking in Denver by the Behavioral Risk Factor Surveillance System over the last 7 or 8 years. So you can see it's about 26% and not really changing. What's the context for that? Well, we compared Denver County to other urban counties in the United States, and the answer was our rate of binge drinking was the highest in the country, the highest county in the country. Only Arlington, Virginia, presumably because they're driven crazy by being next to Washington, D.C., has an equal rate of binge drinking among adults. This just shows data from the rest of the metro area and the state to show you that we're not a big exception. So there's substantial rates of binge drinking across the metro area, and for the state as a whole, it's at 21%, and that's high. This shows, again, the same comparison, so a comparison to other urban counties in the country. And in this case, we're looking at an acute health consequence, and that's called alcohol-impaired driving deaths. So this is the percent of all fatal motor vehicle crashes that are related to alcohol. So you can see in Denver, it's about 37%. So over a third of all fatal car crashes involve alcohol in Denver. And again, we were at the wrong end of that distribution across the country. Chronic health consequences of alcohol are also decreasing in Colorado and in Denver. This just shows in orange the occurrence of all chronic liver disease deaths, and in blue, those that are attributed to alcohol. And again, in national data sets, you can show that the biggest increases in alcohol-related liver deaths have been among young people, particularly young women. So what can we do about it? That's just a quick run through about alcohol, the health problems it causes, and some of the epidemiology in our community, in our state. What can we do about it? Well, the first thing I'd argue is that we have policy levers and we're not using them. And I'll talk here in a bit about probably the most important of those policy levers, and that's tax. I think the second thing is we have clear and consistent public messaging about some public health problems. So for example, in any survey of smokers, 2/3 to 3/4 of current smokers will say, I know I need to quit. And I think that's because we've had decades of consistent messaging which ties smoking to adverse health outcomes. So you have that level of awareness, even among people who are currently using. We have nothing like that for alcohol. There are no consistent public health messaging campaigns that I'm aware of, either in the state or across the country. The minimal amount of public health messaging that's out there comes from the industry, and it all says you should drink responsibly, and we'll get into what their marketing also does, but it's not very effective. And so I think that's on one side. On the other side, we have pervasive and very effective marketing from industry. And I want to show you a few examples of that. So this is sort of classic alcohol marketing directed primarily at men. And so you can see Johnny Walker in a car race, Budweiser and soccer, basketball and Bacardi, et cetera, et cetera. So this tie between sports and alcohol is completely firm. And if you want to see that demonstrated to you, go to our own Coors Field and see alcohol of all kinds available any place in the stadium. And at the bottom, again, shows sort of classic male-oriented marketing of guys having fun, presumably watching sports at the bar. This is what's changed in the last decade or so. The industry's put a tremendous amount of effort and money into marketing for women. And so you see things like cupcake vodka and skinny girl margaritas and mommy's timeout wine. And one of the most popular drinks right now is hard seltzer. So that's White Claw hard seltzer out there. And the woman in the pictures, you can't read her t-shirt that well, but it says, ain't no laws when you're drinking White Claws. Interesting bit of marketing there, sort of alcohol drinking as rebel. And then something directed at older women, tonight's forecast a 99% chance of wine. So this has been highly effective marketing. There's been, as I showed you, increases among women in all alcohol use. There have been particularly notable increases in the use of distilled spirits, which traditionally women didn't drink, and yet now do to a substantial degree. So we are completely losing, in my view, the public messaging war. There's also significant gaps in medical care. We don't have a standard like we have for tobacco about screening for excessive alcohol use. For example, in any electronic medical record that's sold in the United States and certified by the federal government, there has to be the parts of the EMR that screen for tobacco use at every visit. Nothing like that. You can screen for excessive alcohol use, but it's not an obligatory part of the EMR. And we don't use it like that. I'm a primary care provider. We don't, I think, have clear messaging from healthcare providers like we do, I think, often with tobacco. There is medication-assisted treatment that gets most of the press for opioids, but there is medication-assisted treatment for alcohol, and it's moderately effective, not as effective as it is for opioid use disorder, but it's markedly underused. And then we have, I think, poorly coordinated and tremendously underfunded treatment programs, and they often don't include all the levels of treatment that our patients need. And they're very, very underfunded. And then finally, I don't think we have clear and evidence-based harm reduction. We don't use harm reduction strategies for alcohol. We use them for injection drugs, but there's been very little, at least in our community, about harm reduction for alcohol. So my summary is that Metro Denver and really Colorado has a drinking problem, and things are getting demonstrably worse, particularly among women. And this is a critical underlying cause of a very broad range of adverse health outcomes. And notably, that's for individuals, for families, and for entire communities. And we have this tremendous paucity of efforts to control and prevent this. So for example, as public health departments in Colorado, we all get funding for tobacco control that helps us in developing messaging and programs with healthcare providers on a whole variety of things. We have nothing for that for alcohol. There's no ongoing public support for public health programming or public health messaging. Interestingly enough, both at the local and at the national level, there's no advocacy organizations that focus on alcohol. So if you do tobacco work, for example, there are well-funded, very smart, very effective advocacy organizations you can work with, like the Campaign for Tobacco-Free Kids. And they're incredibly helpful in helping you with messaging or ordinances or laws or any of that. Very, very knowledgeable. There's nothing like that in the alcohol field. And then there's this tremendously neglected area of substance use disorder treatment. I'm happy to say that in Colorado, there's going to be an expansion of Medicaid. It's either next year or the following year for at least some increase in substance use disorder treatment. So what can we do about it? The first thing is to talk about state taxes. Ours are currently trivial. And the point of a tax is that it itself works. That's been demonstrated very conclusively with alcohol, just like with tobacco. Price works to decrease use of alcohol. And the important point is if you then use those taxes for the kinds of things we've talked about, for consistent funding, for public messaging, for expanded access to treatment, et cetera, then you get a double benefit from tax, the price itself and the proceeds from the tax being used in appropriate ways. We need public information that is consistent and clear about excessive drinking. We have nothing like that at present. And we need to move forward with common sense limitations on industry marketing, as we've done with tobacco. For medical care, we need to increase screening in a number of places and then have integrated treatment. That is, you don't have to go to a different place to be treated for at least some degrees of alcohol use. You can be treated right where you're being seen, just as we've done for other behavioral health disorders. And then finally, we need funding for the full spectrum of alcohol use disorder treatments across a spectrum. And then it's time to talk about harm reduction for alcohol. There's been a long history in alcohol of saying that abstinence is the only treatment. I think that's not true. There's plenty of evidence with treatment programs that emphasize moderation, not necessarily abstinence. And we also need to think at the end of the spectrum with very severe alcohol use disorder of what can we do in a harm reduction sense. And a number of communities have used what's called wet housing, and that's housing often for people who are experiencing homelessness, which you are allowed, and in some cases provided with alcohol to use. And that's a little hard to think about, but the idea is to have the drinking occur inside, not outside, so you don't have people with frostbite and even death related to exposure, et cetera, et cetera. And it's worked in other communities. Just on the subject of price, here's the data. Colorado has the 39th lowest tax on wine and the 46th and 47th lowest on beer and spirits, respectively. Interestingly enough, the taxes on alcohol were really, when they were put in place decades ago, quite meaningful, but because they're an absolute amount, inflation has worn them away. And so depending on whether it's wine, beer, or spirits, the effect of inflation alone has been to decrease the effective tax on alcohol by 84 to 92%, making them truly trivial. And if you look at what may be one of the key comparisons, the estimate is that the excise tax on alcohol pays only 7% of the total cost of alcohol-related health problems in Colorado. Again, a trivial amount. And just to see how different it can be, I added at the bottom there the spirit tax per gallon in Colorado and in the state of Washington. So 16-fold difference. There are places that tax alcohol a lot more than we do. So I talked about that, those possible interventions. I wanted to leave you with some resources. So the comparisons I used earlier on, we found to be very useful in meeting with people in our community. That is to compare Denver to what Denver considers its peer urban communities. That's been really valuable for us. And you can do that yourself by going to the county health rankings, and you can compare your county to any other county in the United States. And so you can pick what people in your community would consider to be peer counties. So quite valuable. And then the surveys that we used are there: Healthy Kids, Behavioral Risk Factor Surveillance Survey, the Pregnancy Risk Assessment Monitoring System. There's some information on alcohol policies. And then finally, the email address at the State Health Department. Casey Crawford's a great epidemiologist who is focused, funded by CDC, to focus on alcohol epidemiology, and very, very helpful. So I'll conclude by saying that Colorado has a drinking problem. It's serious, and we can do something about it. And I'm happy to take questions.
Wonderful. Thank you, Dr. Berman. I don't see any questions thus far in the Q&A chat box, so please go ahead. If you have any questions that you'd like to be read aloud, please feel free and type those into the chat box. I'll start out giving folks a minute by just asking you, Dr. Berman, if you could speak directly to what Denver Public Health has really been thinking about starting with on this issue, and how you're sort of approaching what comes next for you on this topic.
Yeah, thanks. The first thing we did was bring a speaker from Boston to come in and really teach us and teach other people interested in public health in Denver together. His name was Tim Namey, and he was fantastic. He's one of the leading researchers in the field, and he really helped us think a lot more carefully about alcohol. So for example, the data I showed you about tax and how it's been eaten away by inflation is from Tim's group, for example. So that was very helpful. We did a press release called Denver Has a Drinking Problem. We thought we'd get flack from that. We actually didn't. We had lots of interest from the newspaper, some from television, quite a bit from websites. Most of it quite positive. We actually didn't get the pushback that we suggested, including some quite interesting stories. For example, the Colorado Sun published a story that included things about people who've identified so-called mocktails, that is, they can go out with their friends, be in the environment of a bar and yet not drink alcohol, that's a trend. It had a section about a tailgating area at the Denver Broncos games in which people don't drink. There's a thought. A tailgating party at a football game that doesn't include alcohol. So it was an interesting response. What we're working on right now is trying to get funding to both do a more detailed study about the impacts of alcohol on our community, and then to develop and try out some public messaging. So we're hopeful.
Great. Then we have our first question from the chat box from Nancy, who asks, are there any harm reduction strategies or programs for alcohol that you think are good examples?
Well, I talked about so-called wet housing, and I think, frankly, that it's time for wet housing in Denver. Again, when we're taking 30 people a day or more off the streets with public intoxication every day, it's time to try something else. And wet housing strikes me as an intervention which could be effective. And the whole idea is people will drink, and they may well drink to intoxication, but that the risks of severe adverse health consequences of that will be less if they drink inside their own place, and where there may be access to some other interventions, staff that might help, for example. The second one I talked about was offering a full range of alternatives to people with some level of alcohol misuse, including programs that include moderation. That is not saying there's one way to treat alcohol misuse, and that's abstinence. So I think those are two examples. I'm certainly interested in others.
Great. The next question comes from Taryn, who asks, how do you recommend communities start these conversations, given how socially normal and acceptable alcohol is, and especially when the community might be more focused on wanting to address marijuana?
Great question. The first thing I'd suggest is get some data that's local. The local data may not be any different than state or national data. Oftentimes it isn't different in some important way. But my experience in working with the Denver community and with Denver policymakers is that local data engages people unlike state or national data. It really it's interpreted in a different way. The second thing, and I mentioned this, is try to have comparisons that will strike the decision makers and the community as being relevant. So I can tell you, years ago, when we first started looking at the county health rankings, we could only compare ourselves to other counties in Colorado. And I got to tell you that was never very compelling for Denver, because people would say, yeah, but we're different, we're Denver. And that's true in some senses, but it's not true in a lot of it. We just could never use the county health ranking data to engage stakeholders very well. But when we started comparing to other counties that Denver thinks of as its peers, Seattle, King County, Portland, Multnomah County, where Portland's located, San Diego, et cetera, then people pay attention to it in a different way. That we're all built to compare ourselves to our peers, and counties are no different than that. People want the context that's compelling, and I think the context is compelling will vary, but if you can find comparisons that will strike the stakeholders as being relevant, I think you'll get a lot further. So I would start with that. Try to get local data. That's why we put that slide in there giving you access to some local data, and then try to find comparators that will be of relevance. What we've said is that alcohol is not the only problem, nor are opioids, nor is cannabis. It's just the biggest problem, demonstrably the biggest problem. And I think that can help engage people. I agree. That's why I started with that slide about the complexities of our relationship with alcohol. It's at the center of some of our most sacred and most valued celebrations, weddings, church ceremonies, etc. And yet it causes major health problems. So I think you just have to acknowledge that complexity and move past it. What you can say, and this comes from Tim Namey again, who came to us, is you can say unequivocally, these definitions of excessive alcohol use are without question associated with adverse health outcomes. So there's still this debate about, does a drink a day decrease your risk of cardiovascular disease? I don't even get into that debate. What he said is focus on binge drinking. That's where the health problems lie in large part, and that's where you can focus your messaging. So that's some suggestions.
Great. And then we have a question from Chris about whether there have ever been campaigns to increase the alcohol tax in Colorado.
Yeah, it's a great question. Not that I know of. And the current taxes go back to the 1930s, if I remember correctly. So they're not that long after the end of Prohibition. And they, like a number of taxes, like the current gas tax, it's set as a specific amount. And so what happens over time, inflation, is that just steadily eats away at the effective tax. So I'm not aware of an organized effort to increase the state alcohol tax, but it needs to be done.
Thank you. Tara has a question. She asks, while rates of alcohol use have gone down among youth, rates of marijuana use among youth have gone up in Colorado. Can you speak more about that association?
Well, so I think the rates of both are concerning. I will say the best data says that the rates of marijuana use in youth in Colorado have decreased in the era of legalization. That's a surprise to most people, but look it up. It's on the state's website. You can download the data that show that marijuana use has decreased in the era of legalization. It's still too high, but it has decreased, not increased. Interestingly enough, that's true in other states in which marijuana has been legalized. So it's not just Colorado. What do you do about it? I'm not sure. I think at least some of the messaging is happening. And I think the limitation of sales to people over 21, at least unless it's medical, helps with cannabis use. But we need more effective messaging about cannabis use as well.
April asks specifically about if you know if any of the temporary housing that Denver Health is building for patients will be wet housing.
Yeah, so a couple things. Denver Health is not building any housing at present. We're working with the Denver Housing Authority, and they are rehabbing a building, and we will lease back one floor. So it would be nice if we were building housing. We're not building housing. And those 14 rooms will not be used for wet housing. But we're exploring with the Colorado Coalition for the Homeless whether they might do that.
Great. And Melanie has a question that brings us back to talking about youth. How can we better prepare youth for the pressures to abuse alcohol or binge drink and be at risk for substance use disorder in adulthood?
I'm not sure. And the first thing I would do is ask youth what they think would help them. One aspect that I would start with is part of the problem is about perceptions, and you can see it with alcohol. And if you go into the Healthy Kids website, you can see the data. If you look at what they ask a question about, how much do you think other kids are drinking? And routinely, and it's true for other drugs as well, the youth overestimate the use of drugs in everybody else. That is, they think it's almost universal, and it isn't. So that's the first thing, is to have them use correct data, have them be aware of what truly use is like among their peers. That's a piece. And the second thing I would come back to again is ask youth, because old people like me shouldn't be the ones to identify effective messaging for youth. And the example I use is from tobacco. And so it's been clearly shown among youth, if you want to get their attention about tobacco, talking about serious, and they are serious, fatal health consequences that might happen in 30 or 40 years doesn't work. Clearly doesn't work. What does work? Well, interestingly, the Truth Initiative in Florida identified that youth hated the fact that the tobacco companies lied to them. So the whole basis of the Truth campaign was to say, you've been lied to. They didn't talk about health impact at all. They just talked about how the tobacco companies had disrespected you by lying to you. And that's an example of going to youth to figure out what the effective messages might be. Don't ask old people like me.
Great, thank you. Nami asks, how do we prevent wet housing and detoxification programs from disproportionately impacting the poor?
I don't think you can. I think rich alcoholics are much less likely to need wet housing. They probably can. I will say a couple things. First, it's probably a misconception to think that alcohol misuse is more common among poor people. It's not. It's the reverse. So binge drinking is more common among white and more wealthy people. So that's just one interesting fact about alcohol epidemiology, which is different from many health problems. Secondly, I think public housing of whatever kind is most likely to be used by poor people, and I think that's fine. I think we need to make it available to the low-income people in our community. So that's how I see the question quite differently.
Great. And then Isaac asks, how much were these data on local alcohol issues part of the discussion in the run-up to recent legislation changes that permitted greater availability of full-strength drinks in the community?
Great question. Not at all is the answer. And that's unfortunate, because it's a great point that what we've done in our state and in our country, the policy actions in the last 5 years have all been to make alcohol cheaper and more available. The cheaper part is that a little known part of the recent tax cut at the federal level decreased the federal tax on beer. That slipped through with almost no notice. And then, as the questioner pointed out, in Colorado, what we've done is make alcohol much more available by making full-strength beer available in grocery stores. And I don't think this data came up at all in that discussion, and should have.
And then April has a question about whether Denver Health is participating in implementing screening, brief intervention, and referral to treatment, which she abbreviated as SBIRT, if you're familiar with that.
Very familiar. I think it's a good program. Yes, and we'd like to do more of it. So it's being done in our emergency department. It's being done in some other clinics. We think it's one of the things that we need to expand system-wide. And the analogy we're using is the work we've done with tobacco, in which we've tried to make every part of the system ask, advise, and intervene for tobacco. And that's been very effective. We've dropped our adult smoking prevalence over the last 7 years from 27% to 18%. So I think consistent messaging from healthcare providers works. That's the message of those data to me. And I think we need to apply that to alcohol. So we are, but not in a true systematic, consistent way.
Great. That was the last of the questions from the Q&A chat box. So I would urge anyone who has a follow-up to any of their questions, or anyone who hasn't asked a question yet, you're welcome to unmute your phone line and ask a question to Dr. Berman directly. So feel free, be conscious of speaking over others.
Dr. Berman, it's Stephanie from Mile High Health Alliance.
Stephanie?
And my question is, in my work, I have worked with primary care providers that balk at the idea of screening because they fear it's going to open Pandora's box and they're not going to be able to have resources for them to refer their patients. And so it's kind of like, it's better to not know than to know. Any suggestions on how, I mean, my work is going to start up again with providers related to alcohol, and I just have no idea how to approach that.
Yeah, Stephanie, I think it's a great question, and it's a frequent objection of screening, not just for alcohol, but a number of other kinds of screening, like intimate partner violence or social and economic barriers to care. There are those same feelings of, I can't screen because I won't know what to do with the answer. The SBIRT model appeals to me because the core of the SBIRT model is to say you as a care provider have an important role in identifying, for example, occasional binge drinking and intervening, because the intervention can be right there, right at that time. And it's simple and clear messaging. That's what we've done with tobacco. We don't rely on specialists to help us with tobacco cessation. We've trained our providers to do short interventions, 5 minutes themselves, and we have some backup for the person who wants it. But really, the idea of SBIRT is to identify people with lower level alcohol misuse and have the intervention be to a significant degree right then, right there, by the provider. So I don't think that necessarily gets by all of their concerns, but it may with some. And I guess the other thing you could say is that there are increasing resources going to substance use disorder treatment in Colorado. Medicaid has committed to increasing funding for those, and so there should be more of a backup than there is. But Stephanie, you're absolutely right. I've heard the same thing, including from addictions experts, that same reluctance. So we're gonna have to work with it.
Thank you.
Are there any other questions on the line? If folks want to unmute their phone call, welcome to go ahead and ask. I had one more question while we're waiting for someone else as well. I was curious how you think our transit systems in Denver play into this conversation as well.
In what way?
I've lived in other cities, and noticing how folks may spend their Friday or Saturday night out, but then have a harder time getting home potentially because of our transit system or the lack of that last mile connection to their home or something like that.
Yeah, I think it's a good point. There's been efforts. So RTD frequently makes all of its services free, like on New Year's Eve, to try to encourage people to use it. but it's a more general problem of increasing access to public transportation that includes that last mile. It's a problem. We could do better. I think Lyft and Uber have probably helped in addition to that. And that's actually, I think, the one area of alcohol public messaging where we've done a reasonable, not a perfect, but a reasonable job of setting out the expectation that you don't drink and drive. It still happens too much. But if I think back to when I was young, many years ago, there wasn't nearly as much social norm around drinking and driving as there is now. So more needs to be done, but it's a start.
Great. Does anybody have any last thoughts?
Hi, this is Kim Boyd, President of the Colorado Public Health Association. Thank you, Dr. Berman, for being here today. I just had a quick question and wonder if you might reflect on what an organization like CPHA might be doing to support the public health workforce around the topic of alcohol and alcohol misuse.
Yeah, thanks, Kim, and thanks for the opportunity to speak. I think it's a great question. I think sort of taking off the cartoon on the screen, I think the first thing is to acknowledge the elephant in the room, because I think we all recognize alcohol as this complicated substance that many of us use and yet too many of us misuse. And to be forthright about that, it's not a simple subject and we don't have a simple message. The second thing I think would be to give alcohol its due. Again, this is the cause of 100,000 premature deaths per year in our country. And again, we have consistent public messaging and programs in a variety of areas that aren't as important as this one is to overall community health. So that reflects in part the lack of effective alcohol taxes and hence the tax revenue that could be used to do that. But it's time for us to start highlighting just how impactful alcohol is on health in the meetings that we put together, the speakers we put together, how we run the meeting. I think in all those ways, we need to acknowledge and start to deal with the elephant in the room.
Thank you. There was one more question from the chat box about the rising trend of STDs across the US and locally. Do you think there is or know of any data supporting a connection between increased excessive alcohol use and the increased prevalence and incidence of these infections?
I think it's a great question and one that I've wondered about as well. I haven't yet tried to find data on that, although I've challenged our STD program to see if they can find some. I certainly wonder about it because you see these increases in some of the same populations in which you've seen this marked increase in binge drinking. So I think it's a great question that should be evaluated further.
Great. Any last questions from the audience?
Well, thanks so much for the opportunity to speak.
Yeah, thank you so much, Dr. Berman. We appreciate your time today, and thank you everyone for joining the call and spending your lunch hour with us. If you'd like to follow up with Dr. Berman, feel free and reach out. I put my email address if you'd like the slides or the recording for this webinar, but I can also connect you if you have any other further questions.
Yeah, happy to get questions.
All right, great. Thank you everybody for your time.